This is Ask a Doc. I'm Christy Sexton, National Manager for the Crohn's and Colitis Foundation, and I'm here with Dr. Kalra with South Denver Gastroenterology. Welcome, Dr. Kalra, and thank you so much for joining us today.
Thank you. Great to be here. Thanks for having me.
Absolutely. Before we get started and jump into our patient questions, tell us a little bit about you and your work that you do.
Yeah, so my name is, again, Ankush Kalra. I'm a gastroenterologist with South Denver Gastroenterology. We're a large group serving the Denver metropolitan area and surrounding communities. And we care for a wide array of gastrointestinal and liver conditions, and inflammatory bowel disease is a big part of our practice. And we have a great team within our practice, a team of providers, nurses, and staff dedicated to the care of patients with IBD or inflammatory bowel disease. And yeah, we're very fortunate to be in this position to help folks navigate these challenging conditions.
Awesome. So a great expert to have with us today. So.
Thank you.
All right, we have some patient questions that we're just going to go ahead and jump into and get started. First question, how does someone get Crohn's disease versus UC, ulcerative colitis?
Yeah, really good question. Very complex and likely multifactorial. I mean, the pathogenesis and the mechanisms by which these conditions develop is certainly complex and likely multifactorial, and something that it's worth mentioning when we're diagnosing these conditions newly. A newly diagnosed patient can understandably have a host of emotions, and it's important to mention when making a diagnosis, I think that it's not something that necessarily is within the patient's control in terms of did the patient do something or eat something or live a certain way. We can't necessarily point to something like that, but likely it's a combination of things: genetics, environmental factors, and likely a combination, an interplay between those two, and also for inflammatory bowel disease, the gut microbiome, which is something that our understanding of this kind of nebulous conglomerate of microorganisms that live in our guts is evolving over time, and how the gut microbiome plays a role. In terms of genetics, genetics is definitely a big risk factor. It's considered to be the #1 risk factor, in fact, developing, and perhaps even more for Crohn's versus ulcerative colitis, approximately 20 times increased risk of developing these conditions with having a first-degree relative who also has Crohn's or ulcerative colitis. So that's something worth mentioning. Can we predict it or map it out per se? It doesn't necessarily. The answer is no. Typically, it doesn't typically follow that kind of classic Mendelian pattern of inheritance where you can draw a pedigree chart and say, okay, well, mom has this set of genetic profile, dad has this genetic profile or whatnot, and predict is a child going to have it. But it is a strong risk factor. At the same time, it doesn't appear that it tells the entire story. There are definitely environmental factors worth mentioning as well. In terms of, so broadly, industrialization, urbanization has been thought observationally to be a strong risk factor. Looking at nations around the world where inflammatory bowel diseases, Crohn's and ulcerative colitis are most predominant: North America, United States and Canada, and United Kingdom, Australia, so other industrialized countries. The prevalence of IBD is highest in these nations, yet also relatively stable over time. Interestingly, we're seeing that newly industrialized nations, specifically countries in Africa and East Asia, where inflammatory bowel diseases were not historically prevalent, are now seeing the highest incidences of new cases developing over time. And so rates of inflammatory bowel disease are certainly changing around the world, and perhaps it appears that there's a correlation with that phenomenon and industrialization. What more can we say about that? What does industrialization drive? Perhaps is it a change in our lifestyles, a change in our diets, a change in our environments? Is it air quality, changes in our drinking water, changes in the way we eat? Eating perhaps more processed foods would be one thing to consider. Is it there's a hygiene hypothesis as well? Is it increased cleanliness and hygiene within our environment? that is playing a role. And we obviously don't have a precise answer, but it's likely multifactorial, and it's likely multiple factors playing a role, perhaps with our alterations in our gut microbiome over time. So other things to mention, I mean, other risk factors environmentally would be tobacco use, certainly especially for Crohn's disease, causing precipitating flares and causing more severe disease, especially in Crohn's, is something that's for which smoking is certainly a risk factor. Diets, broadly diets that are higher in animal fat, lower in fiber, lower in vitamin D as well, are thought to also be risk factors.
Great information. Definitely something we don't want to diagnose by researching online. We want to see a professional such as yourself to get that diagnosis. Next question. What are some basic distinctions between the various IBD diets?
Yeah, great question. Another common one that we get in our clinics. What should I eat if I have inflammatory bowel disease? And it's definitely complex to answer that in terms of various IBD diets. There are several diets that have been studied and advocated for with regards to inflammatory bowel disease. What is the target there, though? The target typically is symptoms and symptom management, symptom control. And I can't say that we have a diet that is an end-all be-all that will be curative and can maintain remission. And in terms of targets, when we talk about remission, we talk about clinical remission and symptomatic remission, but we have to focus on other targets as well. And we kind of have this concept of treat to target, and treating inflammation is a big part of inflammatory bowel disease. We want to make sure that when we take a look in your colon and in your small intestine, that the inflammation that we maybe saw when we first diagnosed you is healed. And so can I say that we have a diet that will maintain that mucosal healing long-term? No, but is there evidence and evolving evidence in literature that diet can be used to control symptoms and even induce what we call a symptomatic remission? Absolutely. There's evolving and very strong evidence for that, in fact. I think diet and nutrition are concepts that are kind of put together, but diet in a sense feeds nutrition, and it's important to talk about the concept of nutrition, I think, in inflammatory bowel disease. Nutrition IBD patients are at very high risk for malnutrition. Oftentimes we identify that they are malnourished at the time of diagnosis because when your gut is inflamed, you can imagine certain micronutrients, that we test for, iron, vitamin D, vitamin B12, amongst many others, can be poorly absorbed in the gut. And so the first step when it comes to treating these folks is optimizing nutrition, and in a sense that is using the best medical therapies that we have to treat the inflammation in the gut, and that can improve nutrition. At the same time, we know that's not all of the story as well. Symptoms oftentimes persist even after achieving mucosal healing and endoscopic remission, and how do we manage those symptoms? And oftentimes folks with IBD can develop food aversions where that in itself can cause malnutrition, even in the setting of remission endoscopically and mucosal healing. And so that's another important factor to address. I think there are certain diets which we can mention and discuss, certainly, that have been advocated for IBD. One that's not necessarily considered an IBD diet is the low FODMAP diet, and that's an approach to it's evidence-based in folks with irritable bowel syndrome, a totally separate condition, IBS, where there's no inflammation in the gut, but food sensitivities and altered bowel function, changes with bowel movements associated with abdominal discomfort and abdominal pain can occur in a portion of the population, and we call that IBS. And the low FODMAP diet has been studied and shown to be very efficacious in those folks. We can't necessarily say that someone with IBD has IBS also, because IBS is again kind of a diagnosis of exclusion, but the mechanisms by which some of those gut sensitivities, and some of that is driven by activation of what we call the brain-gut axis, can develop in folks with IBD as well. And that's a common phenomenon. And so something that's important to discuss is this concept of the low FODMAP diet. FODMAPs are essentially these fermentable type sugars, simple and complex carbohydrates and sugars that exist in a lot of foods that are not necessarily unhealthy, but can trigger increased fermentation and thereby intestinal distension and bloating and symptoms. And so sometimes folks with IBD respond really well to a short-term low FODMAP diet where we're eliminating a lot of these foods for a short period, typically recommended to be done under the guidance of a registered dietitian, because the thing we worry about with restricting food groups is, again, malnutrition. If we're restricting whole groups of foods, then are we thereby malnourishing someone? And so typically these FODMAP type foods are eliminated for a 2 to 6 week period and then reintroduced. And oftentimes it can be reintroduced successfully. And that's a really important concept to always try reintroducing when you're eliminating, especially a whole food group. So that's one concept. It's not recommended at this time to eliminate or avoid completely an entire food group. And several of the diets that have been studied and looked at for IBD do recommend that or do support that approach. And that would be, there's the specific carbohydrate diet. There's IBD AID or IBD anti-inflammatory diets. There's new and emerging data on what's called the Crohn CDED, the Crohn's disease exclusion diet. And several of these have been shown to be helpful for symptoms. Again, are they able to achieve that endpoint of mucosal healing and endoscopic healing? Not necessarily. Certainly in the pediatric world, that's perhaps a different story for inducing a remission in situations where you have a young adolescent or child being diagnosed with these conditions. And oftentimes what's called enteral nutrition is being used around the world to induce remission, not necessarily to maintain remission, but has been shown to induce remission in children and young adolescents. And that's typically basically a liquid diet that's applied for an 8 to 12 week period. And there's emerging data on the Crohn's disease exclusion diet, excluding kind of pro-inflammatory type foods for a short period of time with partial enteral nutrition, with partial liquid diet, again, mostly for children. And this has been looked at in adults as well and been shown to be significantly inferior, in fact, to medical therapies that we have, particularly steroids, for inducing remission. A trial worth mentioning is the CD-DINE trial, which was done published just last year, and essentially compared a very restrictive diet, this specific carbohydrate diet, to the Mediterranean diet. The Mediterranean diet, more of an approach to eating, really, and the Mediterranean diet has been shown to be helpful in other conditions such as cardiovascular disease prevention, fatty liver disease, diabetes even, and shown to generally be a healthy approach to eating. And essentially this study looked at about a couple hundred patients with Crohn's disease and with mild to moderate symptoms, and showed that within a 6 week period of either of these diets, essentially, they were randomized to this population to these two diets. And with either of these diets, approximately, I believe it was 43 to 46% or so in each of these groups, so about 45% or so of people will achieve resolution of symptoms or symptomatic remission within a 6 week period of applying one of these diets. And so, again, the specific carbohydrate diet is something that's a lot more restrictive. The Mediterranean diet is maybe more something to advocate for because it's not very restrictive and it's essentially focused on eating whole foods, mostly plant-based foods, limiting certain things like animal protein, certainly poultry, red meats in very low portions, low and infrequent portions. Eggs and dairy also generally a low part of a Mediterranean approach to eating. But cheese and yogurt are certainly included in a Mediterranean diet, but it's mostly nutrient-dense whole plant foods and healthy fats. And so And so other things to mention with regards to diet, which we haven't talked about too much, is what do we do when symptoms are flaring, when there's active inflammation that's flaring. And oftentimes we're talking about a low fiber diet in those situations. And that's something else worth mentioning. When the gut is irritated for whatever reason, an infection, active inflammatory bowel disease, diverticulitis is another common condition that we treat and deal with. When things are actively inflamed, low fiber and limiting whole foods and foods with skins, nuts, seeds, things that can take the things for which the intestine needs to work to kind of digest and produce, and other irritants, possible irritants, alcohol, caffeinated beverages as well can be beneficial when things are flaring. But I think the take-home point with diet is that there's no one size fits all, really. And there are certain diets, and if we're exploring one of these specific diets, whether it's low FODMAP or exclusion diets particularly, it should really be done under the guidance of a registered dietitian monitoring for malnutrition. But everyone's different, and I think general approaches are limiting processed foods. Sometimes eating smaller, more frequent meals as opposed to over distending your gut with food and liquids. And so 4 to 6 small meals a day, limiting processed foods, mostly whole foods, plenty of hydration and water, and a mindful approach to eating as well, which sometimes comes down to preparing, grocery shopping and preparing meals ahead of time, meal prepping, and those can be general approaches that could perhaps apply to everyone. So.
Absolutely. Great question and great answer. So it's not just as simple as that. All right, next question. Are medications and biologics necessary lifelong or limited based on symptoms?
Yeah, another great question when we're dealing with inflammatory bowel diseases, which are chronic conditions. Should medications and therapies be used long-term as well? And that's a common question we get. Or am I a candidate for stopping therapy at some point? Is this going to be lifelong therapy? Certainly, there are certain medications that we use. That's going to be steroids, for example, that should be stopped after a short period of use. And certain medications, like the steroid class particularly, are considered to have high risk with long-term use, risk of infections, risk of adrenal suppression, osteoporosis, and bone disease and whatnot. And so those are good medications at the same time for inducing remission endoscopically and healing the inflammation. But they're typically used as kind of a bridge to other therapies. So those should be stopped most of the time. Other therapies, so anti-TNF medications are oftentimes used in conjunction with other medications, the immunomodulator class of medications. And so that consists of things like methotrexate, azathioprine, 6-mercaptopurine. These medications have often been used with specifically this anti-TNF class of medications, which consists of things like adalimumab, infliximab, golimumab, certolizumab, and the goal or the purpose of using these immunomodulator therapies in conjunction has oftentimes been to reduce a phenomenon that we call immunogenicity. Immunogenicity is essentially because these are certain types of advanced therapies that our bodies can produce antibodies against. It can reduce that phenomenon and allow these medications to work for a longer period of time. The benefit of some of these immunomodulators in conjunction with the anti-TNF therapies has been shown to really occur within the first couple of years or so of therapy. And risks, which are overall generally low with these immunomodulator medications, have been thought to occur more. Risks are considered more occurring more often after about 2 years or so of therapy. And so really, perhaps using these medications for a short period to reduce the immunogenicity phenomenon and then withdrawing them is another concept that is also evolving. In terms of literature on this topic, there's a trial that came out of France over a decade ago called the STORY, STORI trial, which essentially looked at Crohn's patients who were in remission 6 months steroid-free remission, so sustained remission, not requiring steroids for 6 months, and on combination therapy with an anti-TNF and an immunomodulator medication, one of the medications that we just mentioned. And what they did with these folks is it was about 115 or so Crohn's patients. They withdrew the anti-TNF medication and monitored them over time. And what they saw is that about 46%, I believe, 46% or so of people will flare or need to go back on therapy or relapse within a year. And that number was slightly higher, about 52% or so at 2 years. And so someone in sustained remission on Crohn's on these medications may say, okay, 50-50, I'll take my chances. But this cohort was also followed over an extended period of time thereafter, and it was shown that about 80% or so will flare at about the 7-year mark. And there's additional data on really thousands of patients that's been put together in kind of meta-analysis type studies that's shown that the risk is fairly high. And there are models that have been looked at for predicting that risk as well, certainly. Certain types of patients are not good candidates for withdrawal of therapy, and that's folks who were diagnosed young, have had upper intestinal Crohn's involvement, required escalation of therapy previously. And so there are certain risk factors there, certainly. But there is certainly ongoing and evolving studies and literature on this topic, and certainly drug dose de-escalation is something that's being looked at and something that's being applied with some of the advanced therapies that we certainly can we decrease the dose, decrease the interval, and there's a study on looking at this for adalimumab, which is one of the therapies, the anti-TNF therapies that we use. And a lot of the data that we have on some of these drugs, they've been used in the rheumatology world for other conditions like rheumatoid arthritis, and it's been shown that these therapies can be perhaps the interval at which we administer them. Standard for adalimumab is maybe every other week. Maybe that can be spaced out even longer. And maybe as our, perhaps, hopefully as our understanding of genetic therapies and gut microbiome therapies and dietary therapies as well, as things evolve and our understanding of these conditions and how these medications play a role, how things evolve, then perhaps using therapies in conjunction will be an ideal approach. But still a lot to be learned.
Absolutely. Thank you. Okay, next question. How do I manage stress to maintain my health and prevent flares?
Yeah, another really important topic. Thank you for asking that question. I think it's the first step is to address those things and screen for those things. As providers, we should be asking the questions and screening, and as patients, we don't want that topic to be a taboo topic. The topic of stress, anxiety, and depression, and mental health, because it's an important topic regardless. And in folks with inflammatory bowel disease, its rates of anxiety and depression in particular are significantly higher, about twice, double or so the general population. Approximately 30% or so of folks with inflammatory bowel disease deal with anxiety, and similar numbers, about 20% or so for depression. And so certainly working with our mental health colleagues is certainly one approach. In terms of, is there something that we do, and this is something that we've partnered with the Rocky Mountain chapter of the Crohn's and Colitis Foundation in terms of support groups locally, and those support groups are offered, and certainly talking and meeting with other people who are going through similar things is certainly part of the approach, and can be beneficial. And so support groups are something to mention, but that's also not, again, the whole story. I think partnering with our mental health colleagues can play a major role. And there are certain therapies that have been shown, studied specifically in IBD patients that have shown to be effective. Cognitive behavioral therapy is one of them, which is CBT. And they're newer type. This is not necessarily available within every community or available to everyone. And so there's newer data looking at web-based CBT. And CBT, the goal there is to essentially try to alter the thought process, the negative thought patterns that occur and that can kind of cycle and become uncontrolled, an uncontrolled cycle of negative thoughts. And it's the goal there with CBT is to try to interject and almost flip that negative thought pattern. There are certainly other therapies that have been looked at, meditation type therapies. Gut hypnotherapy would be another one. Sleep hygiene is something that we like to talk about as well, because again, the gut-brain axis can be dysregulated if sleep patterns are dysregulated, and that's kind of setting good sleep habits and routines, and that can certainly play a role. Medical therapies, oftentimes we're deferring to our mental health colleagues if we're talking about medical therapies. A class of medications that we do sometimes prescribe, more so for that gut-brain axis, the visceral hypersensitivity response that can occur in both IBD and other conditions such as IBS. And sometimes we use a class of medications called neuromodulators, which may involve selective serotonin reuptake inhibitors, norepinephrine pathways as well, and tricyclic antidepressants. And so that's something that we sometimes use in low doses, but definitely these are conditions that we should be screening for and talking about. And it's probably understated, and yeah, hopefully that answers your question there.
Yeah, absolutely. Some helpful tips for those non-patients as well in there too. So
yeah.
All right. Next question. What labs are important to monitor while on biologics, and how often?
Yeah, good question. We frequently send folks to the lab to get lab work, and it's important to know why. What are we looking at? And it depends. With certain biologic therapies, it depends on the disease course and where you are in your journey. Are you earlier on? Typically, if we're starting new medications, we're checking labs within a few weeks or within a month. Certain medications that we use, aminosalicylates, for example, such as mesalamine, can rarely affect kidney function. And some of the other medications that we use can sometimes cause changes with liver tests or with, again, kidney function, sometimes with the immunomodulator class of medications such as azathioprine can affect blood counts and things like that. So oftentimes early on in therapy, we're doing labs and recommending that we get labs more frequently. In folks who are on advanced therapies and in sustained remission, and we're checking in maybe every 6 to 12 months and getting labs at that interval. Sometimes more frequently every 3 to 4 months if we're making changes. Specifically, we're checking things like kidney function, liver tests, kind of basic labs, electrolytes and blood counts, etc. There are certain other labs that that should be checked as well, especially before initiating advanced therapies. We screen for hepatitis B and ensure that you don't have dormant hepatitis B that could get reactivated. Quantiferon TB or screening for TB or tuberculosis is something else that we do. And we typically, in folks who are on advanced therapies, we typically check that periodically, sometimes annually, for tuberculosis. Another important lab test that we monitor are inflammatory markers. And the role of labs is not necessarily just to make sure that everything's status quo, but it's also to be proactive and to get one step ahead of any sorts of flares and inflammation, and make sure that these therapies that we're using, whatever the medical therapies are that we've implemented, that they're going to continue to work. And can we predict a loss of response to some of these medications or a flare before it happens? And so using targeted inflammatory markers, gut-specific inflammatory markers, like a stool test called the fecal calprotectin, is something that we use periodically as well. And that's, again, a gut-specific inflammatory marker. Definitely has a role with ulcerative colitis and Crohn's involving the colon as well. Nutritional markers are certainly, we talked a lot about nutrition, and nutritional markers should be monitored periodically, regardless of what types of therapies we're on. And that can also sometimes be a hint if we see that iron levels or vitamin D, B12 levels are dropping. All of a sudden, that could be a hint that, okay, is there inflammation driving that process? Is that why those numbers are dropping? Another concept in our field is proactive therapeutic drug monitoring. And we have evolving data, many years of data with regards to certain therapies like the anti-TNF class, but evolving data with some of the other advanced therapies that we use as to how to use proactive drug monitoring. And our GI societies recommend doing this as well because it's been shown to be not only preventative, but also cost effective. Can we check drug levels and screen for production of antibodies to the medications that we're using and predict loss of response ahead of time? And if we see that things are not in an ideal range, then we either switch therapies if necessary, or we optimize therapies and do a more frequent dosing interval or increase the doses. And so staying one step ahead of things is kind of the goal. But yeah, the goal is to get you feeling 100% and keep you feeling 100%. And so being proactive with blood tests, stool tests, sometimes drug levels is an approach that we use commonly.
Great, thank you. Next question, any recommendations for managing many specialists or my healthcare team? And I know you mentioned before a registered dietitian and some mental health partners. How do I ensure that they're all talking and working together?
Yeah, good question. In an ideal world, we're all meeting together, right? And we all get together, and certainly there are certain scenarios where a conversation is required, and we absolutely want to pick up the phone and talk to folks. If we're one scenario is extraintestinal manifestations or manifestations of inflammatory bowel disease that occur outside of the gut, where we need to decide on the best therapies if someone's developing eye manifestations such as uveitis or skin manifestations. We need to talk to our ophthalmology and optometry colleagues, and we need to talk to our dermatology colleagues and whatnot if we're certainly coordinating care together. And you mentioned a big role is our dietitian colleagues and our mental health providers, and we need to all be on the same page. And so that's certainly very important. Another important member of the care team is the primary care provider. And certainly we rely a lot on primary care colleagues for certain health maintenance issues as it pertains to IBD, and that's ensuring, especially when we're prescribing these advanced therapies, which are in the realm of immunosuppressant type therapies oftentimes, and we want to make sure that that folks are vaccinated against common community-acquired infections, influenza, COVID-19, of course. Pneumonia is another one that commonly is not recommended for young folks, but for folks on systemic immune suppressant medications, getting vaccinated for pneumonia is another big one. For certain therapies like the JAK or Janus kinase inhibitors, that would be tofacitinib, a newer therapy, upadacitinib, which is recently approved. Zoster shingles is something else for which folks should be vaccinated, ideally ahead of time before starting these therapies. Cancer screening, again, we typically talk a lot about colon cancer screening. There are other types of screening, and folks who are on systemic immune suppressants that require coordinating with other colleagues in our communities, and that's cervical cancer screening. Typically, more frequent cervical cancer screening is recommended every 1 to 2 years. Skin cancer screening, folks on systemic immune suppression are low but slightly higher risk for melanomas and non-melanoma type skin cancers, and so an annual skin exam is recommended. And so certainly this requires coordination, and I think the Crohn's and Colitis Foundation also has a checklist which helps with some of these things, and I think it's great when patients are also patients are the most important member of the care team, right? And when patients are really involved in their care and involved in the decision-making process, that's really helpful as well. And I think it starts with establishing relationships with trusted providers in the community and maintaining those relationships over a long time. And I think that's something that we really focus on a lot, because it's hard to maintain that therapeutic relationship without really developing a personal relationship and a trusting relationship. And so that's kind of a big focus for us as well.
Patients' healthcare is certainly a collaborative effort.
Absolutely.
Well, that concludes all of the patient questions that we have. Any final thoughts as we conclude today?
No, just thank you all for your thoughtful questions. It was hope my answers were helpful, and yeah, just there's a lot to look forward to in terms of newer therapies. There's a lot of research being done on how can we use therapies together. Newer targets of therapy have really come to light over the past year or two, and these advanced therapies, small molecule type therapies, and again our understanding of gene targeted therapies and gut microbiome type therapies and how we can use these in conjunction. I expect that and hope that it's going to continue to evolve, and so stay tuned for that. I'll be staying tuned and looking forward to the Crohn's and Colitis Congress in Denver in January as well. And so looking forward to hearing those updates, but otherwise just thank you all for your time and for your questions today.
Great. Well, thank you so much. And thank you all who joined us today. And a special thanks to the South Denver Gastroenterology for their continued support for the Crohn's and Colitis Foundation. So many thanks.
Bye-bye.
Bye-bye.